Hi, everybody. It's Sahil Parikh from Columbia University of New York, and I'm delighted to be here for another SCAI Conversations in Interventional Cardiology episode. This week, we're going to talk with three leaders in our field about balloon pulmonary angioplasty for treatment of chronic thromboembolic pulmonary hypertension. We have with us tonight a senior author of this review manuscript, Dr. Vikas Aggarwal from University of Michigan. And we're really honored to have two past SCAI presidents, Dr. Ken Rosenfield from Massachusetts General in Boston, and Dr. Shami Mahmud from the other coast, from UCSD in San Diego. Guys, welcome.
Thanks for having us.
Thank you.
Thank you for exciting to be here.
Vikas, we have seen your meteoric rise in this space, and we were delighted when you offered to lead a series of manuscripts, particularly this one on BPA. Why don't you tell us a little bit about the paper, and then we'll have a conversation.
Sure. So thank you for the kind invitation, and it's an honor to be with this esteemed panel. I'm going to be talking to you guys about this article on behalf of all the co-authors, including Dr. Rosenfield. So balloon pulmonary angioplasty has seen increasing use in the treatment of inoperable and residual chronic thromboembolic pulmonary hypertension. Several different imaging modalities exist for patients with CTEPH, but their use, particularly in the clinical practice of balloon pulmonary angioplasty, I feel is not very well outlined. So in this review article, that's what we try to do, to outline a roadmap for clinicians who are new to the balloon pulmonary angioplasty space to be able to do this in a safe and effective fashion. So pre-procedure planning is always key. Echocardiogram is great for evaluation of the right ventricle, and ventilation perfusion scan is also great for screening for group 4 pulmonary hypertension or CTEPH. It's a very sensitive stool, and it helps identify those with perfusion abnormalities in their lungs. For the pulmonary angioplasty patients, it also helps you identify potential areas or the lobes of the lungs that you could target based on the degree of hypoperfusion. CT pulmonary angiogram, so while is the gold standard for acute pulmonary embolism, in chronic pulmonary embolism space, it's at best adjunctive. In my mind, the biggest use of this technology is to exclude other forms of obstructions in the lung and parenchymal lung disease, such as tumors and ILD and other things. Dual energy CT perfusion angiography is investigational, but we believe has promise to help with lesion prioritization in pulmonary angioplasty. Non-selective invasive pulmonary angiogram is the cornerstone for CTEPH evaluation. It's the gold standard, and it's usually combined with a right heart catheterization. It allows for thorough visualization of the pulmonary vasculature by doing orthogonal imaging. Lesion subtypes can also be visualized. You can get location, distribution, and characterization of disease. And it's probably the best tool to identify targets, as well as to do this, which is to identify disease level, if it's surgical disease or if it's something that should be treated with angioplasty. For the BPA procedure itself, subselective angiography is the key modality that will help you with lesion identification, characterization. You can see a focal stenosis here on this angiogram, and then after balloon dilatation was performed, the stenosis is improved. It should be performed in orthogonal views. Inspiratory hold is recommended. So in most patients, it's crucial to identify the lesion, and we don't recommend subtraction for subselective angiogram to minimize the radiation dose, such as, so this one, it's a total occlusion that's now revascularized. It helps identify the subsegmental anatomy, the number of branches, as well as the type of the lesion. So more examples of the same thing with different kinds of lesion measurements. For intravascular imaging in pulmonary angioplasty space, it's pretty early on right now, and we don't see a great role at this time, although so when in doubt, you could use it for balloon sizing. Pressure gradient measurement is probably more useful. It helps identify significant lesions, especially in the case of webs that are otherwise not super obvious. Post-procedure considerations, in my practice, I do a chest x-ray, so right after the case and then 24 hours after, just in an attempt to identify early reperfusion edema. I have not seen a lot of reperfusion edema in my practice. We do an echo and a right heart cath 3 to 6 months after completing all the sessions, and routine VQ scanning and CT angiograms post-procedures are not recommended at this time. We only do it for recurrent cases or restenosis. With this, I would like to conclude by saying multimodality imaging is vital. You need a team and a multidisciplinary group to get a good, safe, and effective pulmonary angioplasty program going. Future research will help further refine the role of these technologies. And I want to thank SCAI and this panel, as well as all my co-authors for all the work they put in this article. Thank you.
Great, Vikas. Thank you very much. So, obviously we have time for discussion about this really interesting and really rapidly growing area, but I want to put it in a little bit of historical perspective, and that's not to say that you guys are old, but I do think, Shami, at UCSD, you've historically been one of the preeminent centers in the world for pulmonary hypertension treatment, and obviously BPA has had intermittent starts and stops over the last several years, perhaps the last couple of decades. Tell us a little bit about the journey that you've had there at UCSD and how this manuscript helps, put a flag in the ground about where teams should start their programs.
Great. Thanks, Sahil. And as you point out, at UC San Diego, CTEPH has been treated here for over 4 decades. The first pulmonary thromboendarterectomy surgery was done here in the early 1970s. And a lot of people may not know this, but it was done by Nina Braunwald, Gene Braunwald's wife, who was the first chief of cardiac surgery at UC San Diego. So that's in the 70s, and pulmonary thromboendarterectomy, or the surgical treatment, was started in the 70s. We've done over 4,000 PTE surgeries at UCSD over the decades. We did our first balloon pulmonary angioplasty procedures exactly 22 years ago. So in 2000, between 2000 and 2001, we did a number of procedures. And then based on a report that you probably are well aware of, a lot of people are aware of, that came out of Boston Children's, the complications were too high, and we discontinued and restarted our program in 2015. And now, since 2015, we have done about 650 BPA procedures. And now it's really in a very steady state, and we do about 200 BPA procedures and 200 PTE surgeries a year. Vikas's manuscript, I think, is a fantastic addition to the field, and various ways the diagnostic workup has been evolved over the past few decades. And for us at UCSD, echo is the first way pulmonary hypertension is diagnosed. Perfusion scan that gives you a normal perfusion scan virtually eliminates CTEPH as a diagnosis. That gets to making the diagnosis very likely, and then the next step is right heart cath with pulmonary angiography. We do get a lot of referrals of patients who've had CT scans done at various places around the country. But what we do is everybody gets a biplane pulmonary angiogram and a right heart catheterization. And if the baseline hemodynamics are not that significant, but the perfusion scan is quite abnormal, then we include an exercise physiology study in the lab. So we look at baseline and exercise hemodynamics with biplane angiography, and that gets us to our final step. If the patient is not felt to be an appropriate surgical candidate, then we move on to the BPA. And as Vikas outlined, selective angiography is often the best way to delineate which lesions to treat, and then adjunctive hemodynamic measurement, IVUS, OCT, is used relatively rarely. We did it early on between 2015 and 2018. And really the last 3 to 4 years, we've really gotten to selective angiography, not DSA, and aiming for pulmonary venous return, good perfusion. And that's been our current approach. And I would say this manuscript outlines all of those steps in a very organized manner. So for people who don't do this, really read the paper, because it will help you guide your diagnostic strategy for CTEPH first and foremost, and then specifically for BPA if you choose to get into that field.
Great. I mean, Kenny, many of us have learned how to do all kinds of vascular procedures from you over the years, and BPA is an area that you've become deeply interested as a founder of the PERT consortium, and obviously the long-term sequelae, the most dreaded sequelae of PE is CTEPH. Tell us a little bit about your journey and how this manuscript outlines the right steps for programs to initiate themselves and then really get going with this, because this is not every place is UCSD with 200 surgical cases and endovascular cases every year. Most places will start with a more modest approach. How does this fit in with your perspective of building a program?
Thanks, Sahil. And first, I want to thank JSCAI for publishing this in advance, and thank SCAI for the opportunity to talk about this. I think it's incredibly important. It's sort of a hot area. I'll start out by saying I learned everything I know from Shami. Yeah, he succeeded me as president, but I learned everything I know from him. In this area in particular, Shami and his colleagues at UCSD really have been the leaders, aside from those in abroad, Dr. Matsubara in Japan and many others in Europe as well. So, there are people who led before us. Now, our program at MGH started with Rich Chanik coming from UCSD, and he basically was one of the outreach people from UCSD, came and got our program going. And I'll just say that I think it's the critical part about this is the team-based approach. We've all learned, I think, that we have enormous respect for this disease. It is incredibly disabling for that small population of patients who have it, and they are the most unbelievably appreciative of any patients that I've seen, because they're basically suffocating on a day-to-day basis. They can't breathe, and even on oxygen, they can't breathe. And when you do PTE surgery, which is really the first line of treatment, and BPA as second line, if PTE surgery is not possible, that you are giving them back their lives. So it's actually very exciting, and I think you'd agree, Shami and Vikas, that it's really rewarding, one of the more rewarding things that I've done. That said, it's not done in a vacuum, and you can't do it alone. And I just want to emphasize that. I think your paper, our paper, Vikas, really underscores the importance of a systematic approach and a system-wide approach, a team-based approach to figuring out which patients are appropriate for any intervention at all on the diagnostic side, and then within those that actually do have CTEPH and are amenable to treatment, which therapy they should get and when they should get it, how many BPAs, because these are done, as you mentioned, you don't do just one BPA, you're usually doing a series of anywhere between 2 and 12 BPAs on any individual patient. So it really takes a village and it takes a team. And I just want to underscore that. I'll just say one other thing, and this really doesn't come out in the paper, Vikas, but I think it's the next series of papers that we write, which is to say that these are really amongst the most challenging procedures that I do. It's a pretty scary thing when you put a wire out and you balloon dilate, and all of a sudden the patient starts coughing up blood. I mean, instantaneously, there are voluminous amounts of blood, and that can happen in an instant. And it's often unpredictable. There are lots of measures. Shami, you've done a beautiful job of in your manuscripts, and I just refer everybody to your manuscript before this that sort of summarized all about this technique and so on. Done a good job of telling us how to avoid that. But even when you do all the things to avoid it, it still happens. So I would say that the complications, you need to be fully aware and cognizant and prepared for all of these things. And the other thing I would say is that one of the things that make it the most difficult is navigation, is figuring out where are these vessels, which ones are narrowed, how do you get into them, and how do you figure your way about the complex pulmonary vascular bed, which is even more complex in these patients because of their persistent pulmonary hypertension. It distorts the anatomy. So that's our next series of papers, and we'll need everybody to pull together to figure out a better way to navigate in these things to avoid complications and get better results. So thank you for putting this together, Vikas. It really is a step in the right direction to codifying what needs to be done for this procedure and what kind of a team you need to put together.
So Vikas, thank you for your contribution. So tell us, if you had, in rapid fire manner, if you had a 1 minute, what are the most important skills for ICs? Let's say folks that are now getting better and better with acute pulmonary embolism treatment. What are the skills that an operator of that sort would need to acquire before they would even attempt a BPA? Let's assume you have a team that you've assembled, and now you need to pick up some technical skills. What are the most important things?
Number one is get good at pulmonary angiography and interpretation of the diagnostic pulmonary angiogram. You got to know the anatomy. Number two, don't go into this in isolation. Surround yourself with people who can bail you out if there is a perforation. It could be a great friend in cardiac anesthesia, interventional radiology, vascular surgery, a colleague in the cath lab. Make sure you're comfortable with plugging and coiling and those things. Number three, learn the medical aspect and the patient selection and the risk stratification first. If you put the right patient on the table, you're going to have a good outcome. It always starts with making sure you have the right person on the table and you do it. And number four, don't do this in your first year out in practice or second year out in practice. Just get your hands wet, and last but not the least, so reach out to us and ask for help. I know I went to Japan after watching Dr. Bashir, my mentor, do this at Temple. And only then I came back and was able to start this at Michigan. So I'm sure I speak for Dr. Mahmud, Dr. Rosenfield. We are all here to help each other. So reach out. So not everybody has to go through a steep learning curve, and we are all going to make this a success together. Those are the 5 takeaways.
That's fantastic. So Shami, in terms of societal resources and other resources, what do you think are the best educational opportunities for people interested in expanding their skill set here? Having been involved from the inception, really, what do you think are the best resources for people?
Yeah, I think, Sahil, great question. It's something we need to all rally together. Everybody who's on this panel has made efforts to publish not only their experiences, but early on, we wanted to make sure we put down on paper the technique we were using so that others could figure out how to modify it, improve it, or use something. At least there's some kind of a blueprint to follow. I think our next steps are to publish outcomes. The data that's being generated here is more similar to data coming out of Europe than Japan. So we need to understand why the differences. So we have good outcomes. We don't have the outcomes in Japan are actually comparable to PTE surgery. It might be patient selection. So we need to figure all that out. I think from a SCAI standpoint, Vikas and I have actually spoken about this. We want to put together a manuscript that helps guide, a look at the contemporary data and put on paper what we think, what we understand today and what we need to do in the future. But it is a field that is going to take a lot of work. My dream would be that one day in the future, we take segmental and subsegmental disease and randomize against cardiac surgery. The issue is going to be less on our side. I think we can disseminate and standardize our technique, but there aren't that many places that can do subsegmental PTE surgery. UCSD, we do it. But eventually that's going to be an interesting randomized trial. The other part, believe it or not, 20 to 25% of the BPA procedures we're not doing at UC San Diego are post-PTE. So there are a lot of patients who either initially have a response or don't get a great response because the proximal disease is addressed, but the distal is not. So very exciting area. This is the first of hopefully many, many manuscripts that will delineate appropriate imaging, better technique, ultimately tying to outcomes. And as time goes on, I think we can all partner and just get better at it.
And Ken, you've been involved with several of the other organizations, and there's some new alliances that have been created. Tell us a little bit about that.
Obviously, I've been very involved in PERT, which is really initially addressing acute pulmonary embolism, but it really spans the full journey of a patient with PE, and somewhere between 3 and 5%, we believe, of patients with acute PE go on to have CTEF, formal CTEF. There's another probably 40 or 50% that go on to have what we call CTED, or chronic thromboembolic disease. They just don't feel the same as they did before their PE. But for those 3 to 5%, it represents a real number, given the high prevalence of acute pulmonary embolism, which we hope to reduce over time. But there's in response to the sort of requests of people like Vikas and others, the PERT consortium has provided some infrastructure and resources to be able to pull together an alliance, what we're calling the BPA CTEF Alliance, which will be sponsored a bit by PERT. Will basically provide a forum for people to get together and do what Shami just described, is pull us all together to try to figure out how best to tackle this disease. There's a lot that there's more that we don't know than we do know. I mean, Shami's technique is a little different than mine, which is a little different than Vikas. I mean, which one's the right way? I don't know. Which you alluded to this, Vikas. What are the right imaging techniques that we should be using? How do we define which patients go which way and which go the other way? And as Shami said, what do you do with a patient post-PTE, and what's the threshold for deciding to intervene on a patient post-PTE who still has some symptoms? I mean, there's just that's just a few of the things that we don't know. There's so much that we don't know. So we need to get together to say, well, where's the evidence gap, and how do we fill it? And how do we develop consensus around certain issues? So the Alliance is intended to do that. And at the annual PERT meeting coming up in Tampa at the end of September, I think it's September 28th to October 1st, we'll have a couple of meetings of the BPA Alliance. So if it's a good opportunity, if you have a site or you come from a site that's interested in doing this, yes, connect with Vikas and Shami, myself, and other leaders in the field, but also you can come to the PERT meeting and learn and participate in the activities there.
It's fabulous.
I just want to make, Sahil, one quick comment. And it's rare that you look at a paper and you read it and you say, basically, it doesn't need anything to be modified.
Thank you.
It's very important. And so I want everybody listening to this, please read the paper, because I felt that it was really an important contribution to this field, and it will help people understand how to go about a pathway to make the diagnosis, and ultimately, if you want to start a BPA program, to learn the steps to do it properly. So congratulations, Vikas and Kenny, great manuscript.
Thank you. That's the greatest compliment I've had in a long time. Thank you.
And I don't take any credit. It's Vikas. You took the lead in this one, so you deserve all the credit.
I'm delighted. It's a love fest, and we appreciate really immensely the contribution, Vikas, from you and the writing group. We obviously have plans for future manuscripts in JSCAI on this topic, as has been alluded to here. And obviously, it's a fascinating area that's really rapidly evolving, and it's gotten serious traction and is an important area for trainees and for faculty everywhere to be cognizant of. So with that, I want to thank all of our panelists, and Vikas, you especially for contributing this manuscript with your team. And we certainly want to thank JSCAI and SCAI for their support in this endeavor. So that's a wrap for tonight. And again, thank you all for for being here, and we look forward to seeing you on the next Conversations in Interventional Cardiology.